You know that feeling, right? That sudden, startling flutter in your chest, maybe a skipped beat that makes your stomach drop. Or that dizzying moment of lightheadedness that just washes over you out of nowhere. It's unsettling, maybe even a bit frightening.
It really is.
And it's your body, in that moment, sending you a powerful signal, a little peek behind the curtain at the incredible, often hidden electrical symphony that's constantly playing within your heart.
Indeed. It's an exquisitely timed, remarkably complex system, really designed for precision to sustain life. But occasionally, that electrical symphony can encounter interference,
Interference, right?
leading to an unexpected rhythm. This is particularly true within the heart's powerful lower chambers.
And that, my friends, is exactly where our mission takes us today. Welcome to the deep dive, where we're not just touching the surface, but truly plunging into the intricate, often mysterious world of ventricular arrhythmias, or VAs. Now, if you're here wanting to truly master this information, to understand it like the elite professionals in this field, you've definitely come to the right place.
We hope so.
Because these VAs aren't some uniform phenomenon. They span a huge, incredibly diverse spectrum. Some are surprisingly benign quirks that are, frankly, harmless.
Yeah, completely harmless sometimes.
But then others go all the way to incredibly serious, even acutely life-threatening conditions.
It truly is a critical domain in cardiovascular health. And the nuances are not just academic, they are literally life-determining.
Life-determining, wow.
Recognizing which arrhythmias are merely, let's say, transient deviations, maybe needing just observation, versus those which demand immediate, decisive, and often aggressive intervention, well, that's paramount.
Okay.
This deep dive is designed to equip you with that nuanced understanding.
Our mission today is an essential journey for anyone who truly wants to understand these heart rhythm disturbances at a foundational level. We're going to systematically unpack how they manifest in the human body, the precise, often ingenious methods doctors employ to identify and characterize them, and then the cutting-edge, multifaceted approaches available for managing them.
That's the plan.
Our goal, to arm you with the kind of comprehensive knowledge that allows you to feel truly well-informed, fostering a profound appreciation for the precision, the vigilance, and the continuous innovation required in both diagnosis and treatment.
And to achieve this level of understanding, this mastery, we're drawing directly from foundational, authoritative insights, specifically from a comprehensive medical text.
Okay.
So this isn't generalized information. It's a deep dive into highly detailed, evidence-based knowledge structured to build your mastery from the ground up.
All right, let's roll up our sleeves and truly unpack this. We're talking about ventricular arrhythmias. For those of us aiming to master this, what exactly are these at their most fundamental level?
Okay, so at their core, ventricular arrhythmias, VAs, they represent abnormal electrical activities. And the crucial specificity here is their origin. These activities arise exclusively within the ventricles.
The lower chamber.
Exactly, the two large, muscular lower chambers of your heart. To put it simply, these are your heart's primary pumping stations.
Yeah.
You know, the right ventricle pumps blood to the lungs,
Right.
and the left ventricle pumps that oxygenated blood to the rest of your body. So when the electrical signals initiating contractions in these powerful chambers go awry, it directly and profoundly impacts the heart's ability to pump blood effectively,
Which causes problems everywhere else.
leading to a cascade of effects throughout the body. Absolutely.
And you mentioned earlier that they affect a broad spectrum of people. Is this only a concern for those with existing pre-diagnosed heart conditions, or can it genuinely affect anyone?
Yeah, this is an absolutely crucial distinction and one that often surprises people. VAs can indeed affect patients with what we term normal hearts.
Normal hearts, meaning
Hearts without any identifiable structural damage, scarring, or underlying disease processes upon thorough investigation. However, and often more concerningly, they also impact individuals who do have structural heart disease.
okay, like after a heart attack.
Exactly. Could be due to a previous myocardial infarction, a heart attack which leaves scar tissue, or conditions like cardiomyopathy, which is a disease specifically of the heart muscle itself, leading to abnormal structure and function.
Got it.
The distinction between a normal heart and a structurally abnormal heart is absolutely vital. It fundamentally influences the prognosis, the potential risk of sudden cardiac death, and therefore the most appropriate and effective treatment approach. Our diagnostic journey really starts with making this very distinction.
So for clinicians and for us striving for mastery, it's about finding that critical balance. Not overreacting to something potentially minor, but being incredibly decisive when it's genuinely serious. How do professionals frame that approach?
Precisely. It's what we refer to as an appropriately parsimonious approach.
Parsimonious, oh, that's it.
Exactly. Exercising prudence and judiciousness. We avoid unnecessary interventions for those benign forms of VAs that, despite perhaps causing symptoms, pose no real threat to a patient's life.
Right.
Simultaneously, we maintain a very clear, often aggressive understanding and readiness to act decisively when dealing with the malignant, potentially life-threatening forms. The stakes are incredibly high in those latter cases.
Demanding swift action.
Swift and often invasive action, yes. This balanced strategy is really at the heart of modern arrhythmia management.
Now, when we talk about where these abnormal electrical signals come from, it's not always the same source, is it? We have what are called focal sites and reentrant circuits. Let's dive into focal VAs first. What exactly are these, and how do they originate?
Yeah, focal VAs are fascinating because they arise from a single, isolated, what we call an irritable spot.
An irritable spot, like a trigger point.
Kind of like that, yeah.
Yeah.
This spot can be within the heart muscle cells themselves, the myocardial cells, or sometimes from the specialized conduction system, the Purkinje cells. Think of it like a tiny rogue cell or a small cluster of cells that essentially decides to spontaneously generate an electrical impulse when it absolutely shouldn't.
Just fires off on its own.
Exactly. Or it might fire off in response to an abnormal trigger that excites it. These are very precise points of origin.
So it's like one tiny trouble spot just firing off on its own, out of sync with the rest of the heart's rhythm. How does that spontaneous firing actually happen? What are the specific electrical mechanisms at play here?
Well, there are two primary mechanisms through which focal VAs can arise. The first is called automaticity.
Automaticity.
This is a property where cells spontaneously generate electrical impulses without needing any external trigger or stimulation. Now, certain cells in the heart, like those in your natural pacemaker, the SA node, normally have this property.
To set the regular beat.
Right, to initiate a regular heartbeat. But in VAs, this automaticity occurs in abnormal locations within the ventricles or at inappropriate and accelerated rates. It's like a backup generator suddenly kicking on too fast, unbidden.
And the second mechanism?
The second is called triggered activity. This is electrical activity that is initiated by preceding impulses. So, a normal heartbeat comes first, but then it sets off an abnormal aftershock or a series of aftershocks.
Like an echo.
Kind of like an electrical echo, yes. This phenomena often occurs under specific abnormal conditions, like when the heart muscle is stressed, when there are electrolyte imbalances, or when there's an altered cellular environment.
Okay.
It's as if a normal signal, instead of just passing through, leaves behind an electrical echo that then sparks its own abnormal activity. Both automaticity and triggered activity represent distinct ways a single point can become an electrical nuisance.
All right, that clears up focal VAs. And then we have the other major category, reentrant VAs. When I hear reentrant, I immediately picture a loop. Am I on the right track there?
You've hit on the perfect image. Reentrant VAs are indeed a short circuit. Instead of an electrical impulse propagating normally through the heart muscle and then simply extinguishing itself.
Like it's supposed to.
Exactly. It gets trapped. It finds a continuous, self-sustaining electrical loop within the heart. Imagine a circular track where the same impulse keeps running around and around, endlessly re-exciting the heart muscle and causing repeated rapid contractions.
A feedback loop gone wrong.
Precisely. An electrical feedback loop gone wrong.
And what's usually the primary culprit in setting up these short circuits within the heart?
The primary culprit, in the vast majority of cases, is an area of scar tissue.
Scar tissue again?
Yes. It's incredibly common in patients who have had a previous myocardial infarction or heart attack. When heart muscle cells die during a heart attack, they are replaced by fibrous scar tissue, which doesn't conduct electricity normally.
Right, it's not muscle anymore.
Exactly. The scar tissue creates complex, often tortuous pathways that force the normal electrical impulse to detour, slow down, and then, crucially, loop back on itself into the previously excited, now recovered tissue.
And that forms the circuit.
That forms that reentrant circuit. Scarring can also result from a cardiomyopathic process, which refers to various diseases that affect the heart muscle itself, leading to abnormal structure and function that predisposes to these reentrant loops.
So it's the electrical detour around damaged tissue that creates the problem. Are there other less common but still important ways these reentrant circuits can form?
Yes, while scar is the most common substrate, it's important to note for, complete mastery that diseased Purkinje conduction pathways can also form these reentrant circuits.
The specialized pathways themselves.
Yes. The Purkinje system, as we touched on earlier, is normally responsible for the incredibly rapid and efficient spread of electrical impulses throughout the ventricles, ensuring synchronized contraction.
The high-speed highways.
Exactly. When these high-speed electrical highways are diseased or damaged, they can create conditions where an impulse gets trapped in a loop, leading to reentrant activity. While less common than scar-mediated reentry, it's a distinct mechanism requiring specific consideration.
This sounds incredibly complex. So how do doctors actually see these VAs? What's the signature? I know the electrocardiogram or ECG is absolutely key for diagnosis. What distinct features does it tell us about VAs?
The ECG is absolute foundational for characterizing VAs. It's our window into the heart's electrical activity. They are primarily identified by their distinctive appearance and duration on an ECG, and the most critical distinguishing feature you'll almost universally see is what we call a wide QRS complex.
Wide QRS, that's the big one.
That is your immediate red flag for a ventricular origin.
And why is it wide? What's happening electrically that makes that QRS complex look so profoundly different from a normal heartbeat? For us aiming for mastery, understanding the why is everything.
That's a fantastic question, and it speaks directly to the fundamental electrophysiology. Normally, the electrical activation of your heart occurs incredibly rapidly and efficiently.
Through the Purkinje system.
Exactly. Facilitated by that specialized Purkinje system. Think of the Purkinje fibers as high-speed express lanes, delivering the impulse almost simultaneously to all parts of the ventricles. This rapid, synchronized depolarization results in a very narrow, sharp QRS complex on an ECG, typically less than 0.12 seconds.
Okay.
However, in ventricular arrhythmias, whether the impulse is originating from an abnormal focal site or exiting a reentrant circuit, the electrical conduction propagates slower.
Slower? Why?
Because it doesn't use those high-speed Purkinje express lanes effectively. Instead, it spreads directly, inefficiently, and often circuitously through the ventricular myocardium itself, the actual heart muscle.
The muscle cells aren't built for speed like the Purkinje fibers.
Precisely. They're like local roads compared to the Purkinje highways.
So it's taking the scenic route, electrically speaking, causing a delay.
Exactly. This delayed, inefficient, and often asynchronous spread of electricity across the ventricles results in a prolonged or wide QRS complex on the ECG. This complex is typically measured as greater than 0.12 seconds, or 3 small squares on standard ECG paper.
Okay.
This increased duration reflects the time it takes for the electrical impulse to meander through the ventricular muscle. Now, it's important for precise understanding that there are indeed some unusual situations.
The exceptions.
Yes, where a VA might present with a narrow QRS duration, maybe if it originates very close to the Purkinje system, or in other rare cases, but these are exceptions. For mastery, the wide QRS is your strong, almost universal indicator of ventricular origin.
With that foundational understanding firmly in place, let's now truly dissect the diverse forms of ventricular arrhythmias. We hear a lot about PVCs, or premature ventricular contractions. What exactly are these early birds in the heart's rhythm?
Yeah, premature ventricular contractions, or PVCs, are precisely what their name implies. They are single ventricular beats that fall earlier than the next anticipated supraventricular beat.
Comes in too soon.
Exactly. Imagine your heart has a very disciplined drummer, setting a steady rhythm, and then suddenly an extra rogue drum beat comes in before the regular one was expected. It's an interruption, a premature beat originating from the ventricles rather than the atria.
Now, I understand that in medical texts, they often use visual aids. If we were looking at a diagram, or what might be figure 252-1 in a textbook, how would that illustrate the different types of PVCs and their characteristics? Can you paint that picture for us?
Certainly, if you were visually analyzing ECG tracings, like in that figure, you'd see examples that beautifully illustrate the different types. Take, for instance, what we call unifocal PVCs.
Unifocal, so one spot.
Exactly. In this scenario, all the PVCs originate from the same single focus within the ventricle. Because they stem from the identical electrical starting point, they produce an identical QRS morphology on the ECG. Every time that extra beat comes, its electrical fingerprint looks exactly the same.
Consistent shape.
Right. A classic example you might see illustrated is what's termed bigeminal frequency, where every other normal beat is followed by a PVC. So it's normal beat PVC, normal beat PVC.
Okay, that pattern.
What's crucial to understand here, a profound practical detail for any medical professional or observer, is how this can lead to pseudobradycardia.
Pseudobradycardia, false slow heart rate.
Exactly. Your heart's actual electrical rate, sensed by an ECG, might be, say, 100 beats per minute. But because those premature ventricular beats often occur too early in the filling cycle, or are simply not strong enough contractions,
They don't push enough blood out.
right, they might not generate a strong enough arterial pulse to be felt at the wrist or neck. So when checking a radial pulse, you'd only feel half that, maybe 50 beats per minute. The pulse registered is half the actual electrical heart rate.
Well, that's a big difference.
It's a profound disconnect between electrical and mechanical activity and a key diagnostic trap if you're not aware of it.
That's a fascinating practical insight. So the heart is electrically active, but you're not getting effective blood flow with every beat that's happening. What about the other type of PVCs?
In contrast to unifocal, you would then see multifocal PVCs, again like in that figure example perhaps. As the name clearly suggests, these arise from different ventricular sites.
Multiple spots firing off.
Correct. Because they originate from multiple distinct locations, they produce varying QRS morphologies on the ECG. Each premature beat looks distinct from the others, indicating several irritable electrical spots firing off. It's a more electrically chaotic situation than unifocal PVCs. And then a very simple but important definition to add. When you have two consecutive ventricular beats that are PVCs, occurring one right after the other, that's precisely what we refer to as a ventricular couplet.
A couplet, two in a row. Okay. Now, understanding these early birds, what actually causes these PVCs to pop up? I know the source mentions several key factors.
Yes, the underlying causes are quite varied, and knowing them helps direct investigation. PVCs can be generated through the mechanisms we discussed earlier, enhanced automaticity,
Firing on their own.
or triggered automaticity, firing after a normal beat under abnormal conditions. They can also arise from micro-reentry circuits, tiny electrical loops. Beyond the cellular mechanisms, PVCs are notably sensitive to sympathetic stimulation.
Adrenaline, stress, caffeine.
Exactly. States of increased adrenaline like stress, anxiety, excitement, or even stimulants like caffeine can provoke or increase their frequency. So while sometimes benign, PVCs can be a sign of increased sympathetic tone.
But not always serious.
Not always pathological, no. However, they can also point to more serious underlying issues, such as myocardial ischemia, lack of blood flow to the heart muscle.
That's serious.
Very. They might also indicate hypoxia, low oxygen levels, or significant electrolyte abnormalities like low potassium or magnesium. And critically, they can be associated with underlying structural heart disease.
Okay.
Most profoundly, in the context of acute ischemia or pre-existing structural heart disease, frequent or complex PVCs can be a harbinger of sustained ventricular tachycardia, VT, or ventricular fibrillation, VF.
A warning sign for worse things.
Yes, potentially a prelude to more serious, life-threatening arrhythmias that demand immediate attention.
So the ECG characteristics for PVCs aren't just about identifying them. They actually give us critical clues about what might be going on beneath the surface, right? How precise are these clues?
Absolutely. The detailed ECG characteristics can provide vital hints about whether underlying heart disease is present and even where in the heart the problem originates. For example, PVCs that display smooth, uninterrupted contours and sharp QRS deflections.
Looking clean on the ECG.
Right, might suggest the ectopic focus is in relatively normal, healthy myocardium, maybe implying an idiopathic or benign origin.
Okay.
On the other hand, if you see broad notching and slurred QRS deflections, this often suggests a diseased myocardial substrate.
Indicating scar or damage.
Exactly. Indicating the heart muscle itself might be compromised or scarred, which raises a greater concern for structural heart disease.
And the QRS morphology itself can tell us where it's coming from, like which ventricle or even what part of the ventricle. That sounds like an electrical roadmap.
Exactly. The QRS morphology gives us a very strong indication of the site of origin. For example, if you observe a dominant S wave in V1, on the ECG what we call a left bundle branch block-like configuration.
Looks like a left bundle block.
Yes, because it mimics that pattern. This typically suggests origin from the right ventricle or the interventricular septum. These morphologies are often seen in benign idiopathic arrhythmias, less likely associated with structural heart disease.
Okay, that's reassuring sometimes.
Conversely, if there's a dominant R wave in V1, a right bundle branch block-like morphology that indicates origin from the left ventricle.
Left ventricle origin. more concerning?
Generally, yes. This finding is more likely to be associated with structural heart disease and therefore implies a higher potential risk.
So the very look of that QRS on the ECG is a literal roadmap of the electrical impulses journey. What about the frontal plane axis? How does that add to our understanding of the origin?
The frontal plane axis is another crucial piece of that electrical roadmap. Gives us a sort of three-dimensional sense. If you see a superior frontal plane axis, negative QRS in leads 2, 3 AVF.
Pointing upwards electrically.
Yes. Suggests initial depolarization in the inferior wall, the bottom part of the heart. The impulse spreads upwards. In contrast, an inferior frontal plane axis positive of those leads suggests origin in the cranial aspect, the top portion.
So combining V1 shape and the axis.
Exactly. Combining the QRS morphology in lead V1 with the frontal plane axis, we gain a remarkably precise idea of where this electrical problem is coming from. This level of detail, as we strive for mastery, directly helps infer the nature of any underlying heart disease. For example, most benign idiopathic VAs often have that left bundle branch block-like shape with an inferior axis. This comprehensive ECG analysis is foundational.
That's incredibly detailed and truly helps build the mental picture. So from these early bird PVCs, we move up in complexity to ventricular tachycardia, or VT. This sounds like a much more serious rapid run for the heart.
It is indeed a significant step up in seriousness. Ventricular tachycardia, VT, is clinically defined as 3 or more consecutive ventricular beats at a rate faster than 100 beats per minute.
3 or more over 100 BPM.
Right. If you observe 3 or more consecutive ventricular beats, but at slower rates, say 60, 100, that's usually called an idioventricular rhythm or accelerated idioventricular rhythm. Still abnormal, but often less immediately concerning than true VT.
And VT isn't all the same either, right? It's classified by its duration, which I imagine has major implications.
Correct. We distinguish primarily between non-sustained VT and sustained VT. Non-sustained VT is defined as any VT that terminates spontaneously within 30 seconds.
A short burst.
Essentially, yes.
Yeah.
A short burst that resolves on its own. Sustained GT, on the other hand, is much more serious and clinically urgent. It persists for greater than 30 seconds, or, crucially, is terminated by an active intervention.
Like meds or a shock.
Exactly. Intravenous medication, external cardioversion, and a tachycardia pacing from a device, or a shock from an implanted defibrillator. This distinction between non-sustained and sustained is absolutely critical for immediate risk assessment, urgency of treatment, and long-term management.
Now, even within VT, there appear to be many faces. Let's break down the different appearances. Monomorphic, polymorphic, and ventricular flutter. What defines monomorphic VT?
Monomorphic VT is characterized by having the same QRS complex from beat to beat.
Mono one shape.
Exactly. This uniformity indicates a consistent ventricular activation sequence, strongly implying a single, stable source or a single consistent reentrant circuit. On the ECG, you'd see this uniform appearance, often with dissociated P waves, the atria are doing their own thing.
Right.
And as we discussed with PVCs, this consistent QRS morphology provides very strong clues about the precise site of origin, which is invaluable. Knowing the origin often suggests whether an arrhythmia is idiopathic, benign, or associated with structural disease, more serious.
So it's a steady but incredibly rapid rhythm from one spot. But then there's something called ventricular flutter, which sounds even more intense and dangerous.
Ventricular flutter is indeed a very rapid and critically serious form of monomorphic VT. What distinguishes it on the ECG is its unique sinusoidal appearance.
Sinusoidal, like a sine wave.
Precisely. The electrical waves are so rapid, broad, and smooth that it's not possible to distinguish the QRS complex from the T wave. They merge into one continuous, undulating, wavy line. Even relatively slow sinusoidal VTs can show this, indicating profoundly slowed conduction.
And what causes that?
This isn't just an ECG curiosity, it's a critical sign. Possible causes demand immediate investigation. Hypokalemia, dangerously high potassium.
Okay.
Toxicity from excessive sodium channel blocker drugs like flecainide or certain antidepressants, or severe global myocardial ischemia, widespread lack of blood flow. Identifying flutter points urgently to these life-threatening conditions.
From the steady, rapid beat to something that's constantly shifting, polymorphic VT, that sounds like a true shifting dance of electrical activity.
Polymorphic VT is precisely that, characterized by a continually changing QRS morphology from one beat to the next.
All in many shapes.
Right. This indicates the ventricular activation sequence itself is constantly changing, as if the electrical impulse is taking different, unpredictable, often chaotic paths. It's much more disorganized and electrically unstable than monomorphic VT.
And within that, there's a very specific, almost theatrical form called torsades de pointe. This name even sounds like something out of a ballet.
Yes, corsades de pointe, literally twisting of the points, is a distinct and particularly dangerous form of polymorphic VT. What makes it unique is that it occurs in the context of congenital or acquired prolongation of the QT interval.
Long QT interval.
Yes, the QT interval represents the total time for ventricular contraction and recovery. If it's abnormally long, it creates a vulnerable electrical window that sets the stage for torsades.
And what does it look like?
On the ECG, it has a characteristic waxing and waning QRS amplitude. The complexes get bigger, then smaller, then bigger again, coupled with a characteristic shifting axis.
Twisting around the baseline.
Exactly. Visually, it appears to twist around the baseline, truly evoking that classic ballet sequence. It's a memorable image for a very serious, often drug-induced or genetically predisposed arrhythmia demanding immediate attention.
That's a perfect visual to help us master that concept. And then at the pinnacle of cardiac chaos, we have ventricular fibrillation, or VF. This sounds like the heart has completely lost its rhythm.
The ventricular fibrillation, VF, represents the most severe and immediately life-threatening form. It's characterized by continuous irregular activation with no discrete QRS complexes discernible on the ECG.
It's chaos on the screen.
Exactly.
Okay.
Chaotic, disorganized squiggles or a wavy baseline. This prevents the ventricles from effectively pumping blood. Think of the heart muscle just quivering or jiggling uselessly. Blood flow stops. This is cardiac arrest.
And it sounds like the other forms of VT can often lead to VF. Is it a common progression?
Yes, very often. Monomorphic or polymorphic VT, especially if rapid and unstable, may transition to VF in susceptible patients. It's a progression to even greater electrical instability. And critically, the most common cause of VF is cardiac ischemia.
Lack of blood flow, like a heart attack.
Typically due to a heart attack, yes, underscoring the profound link between acute myocardial damage and the most dangerous arrhythmias.
So we've talked about all these serious and life-threatening forms, but you mentioned earlier that some VAs are actually benign. How do we categorize those, and what sets them apart?
That's where the term idiopathic ventricular arrhythmia comes in, and it's a very important category. This generally refers to PVCs, or sometimes brief runs of non-sustained VT, that occur without structural heart disease.
Normal heart structure.
Right, a thorough evaluation reveals no underlying damage or disease. Crucially, they're also not associated with an underlying genetic syndrome, predisposing to serious arrhythmias, and therefore carry no risk of sudden death.
Okay, that's key. No sudden death risk.
Vital. Because for these patients, while the PVCs might be symptomatic, causing palpitations or an unsettling feeling, they don't pose a threat to life. Understanding this allows for appropriate reassurance, avoiding unnecessary anxiety and aggressive interventions.
So with all these complex electrical issues in mind, how do these VAs actually show themselves to the world? What are the common symptoms a person might experience, or how might they even realize they have one?
The clinical manifestations are quite broad, really ranging from subtle sensations to life-threatening collapse. The most common subjective symptoms include palpitations.
That racing, skipping feeling.
Exactly. Feeling your heart race, skip beats, pound, or flutter. Patients might also experience general malaise like dizziness, lightheadedness, or a sudden onset of exercise intolerance.
Can't do what they used to.
Right. More severely, VAs can lead to profound episodes of lightheadedness, syncope fainting, or even, in the most critical cases, sudden cardiac arrest.
Which can lead to sudden death.
If not immediately and effectively resuscitated, yes, sudden death. The spectrum is truly wide.
But it's not always obvious, is it? You mentioned that they can also be asymptomatic. How can something so significant fly under the radar?
That's the silent truth, and a key reason why diagnostic vigilance is essential. VAs can indeed be completely asymptomatic. They might be encountered unexpectedly during a routine physical exam.
Like the doctor hears something funny.
Exactly. An irregular pulse, abnormal heart sounds during auscultation. They can also pop up on a routine ECG done for another reason or during an exercise test, or very commonly detected during cardiac ECG monitoring for other diagnostic purposes.
And that pseudobradycardia thing again?
Yes, we even touched on pseudobradycardia. If every other beat is a PVC, by Gemini, the pulse felt at the wrist might be erroneously low, half the actual electrical heart rate. Because those premature beats aren't generating a strong pulse. The patient might feel fine, but electrically, something significant is happening.
Syncope, or fainting, sounds like a pretty clear red flag that demands immediate attention. When should syncope really raise a high level of concern for a potentially life-threatening arrhythmia?
Syncope is absolutely a concerning symptom, and it becomes particularly alarming under specific circumstances that point directly to a cardiac origin. For instance, when it occurs without prodrome.
No warning signs, just boom, lights out.
Exactly. No dizziness, tunnel vision, nausea before the faint. That's a red flag. Similarly, if it happens during exertion or exercise, highly suspicious for a cardiac cause. And it's extremely concerning if syncope occurs in a patient with an abnormal ECG or known structural heart disease.
Okay. Why is that so concerning?
Such episodes are serious red flags because they can be due to VT that produces severe hypotension. The blood pressure drops dangerously low because the heart's beating too fast to fill properly, or it's ineffective at pumping.
Not enough blood to the brain.
Precisely. That causes the syncope. This situation warrants immediate and profound concern for risk of cardiac arrest and sudden death with arrhythmia recurrence. High risk of a future, potentially fatal event.
So, if someone faints, it's not always an arrhythmia, but it absolutely needs to be thoroughly checked out for that possibility. How do doctors differentiate?
Precisely. It's vital to distinguish these potentially life-threatening cardiac causes from more benign processes. The most common causes of syncope are actually reflex-mediated neurocardiogenic vasovagal episodes.
It's like fainting at the sight of blood.
Exactly, or standing too long, or in response to pain or fright, and orthostatic hypotension, blood pressure dropping upon standing up quickly. These aren't usually life-threatening, but when there's a strong suspicion of underlying heart disease or a genetic syndrome causing VT, then hospitalization for further evaluation and monitoring is often appropriate.
Better safe than sorry.
The stakes are simply too high to take chances.
And what about sustained VT? How does that typically present in a patient who might already have an underlying heart condition?
Sustained VT may present clinically as a wide QRS complex tachycardia on the ECG, rapid heart rate, wide QRS. This is critical for clinicians because it needs careful distinction from supraventricular tachycardia with aberrancy.
Looks similar but different origin.
Exactly. A common and challenging diagnostic dilemma. SVT with aberrancy originates above the ventricles but looks wide, while VT comes from the ventricles. Vastly different implications. Making that distinction quickly is key.
And the symptoms?
They can vary, can be relatively minor, just persistent palpitations or lightheadedness, but more commonly include hypotension with syncope and even imminent cardiac arrest. The danger is ever present, as sustained VT may degenerate to VF, particularly if it is rapid and polymorphic.
Spiraling into cardiac arrest.
Right. Many patients at risk for VT have known heart disease, and many have an implantable cardioverter defibrillator, ICD, preventatively. For them, VT episodes might cause transient lightheadedness, palpitations, or syncope, followed by a shock from the ICD.
Living with that possibility.
It's a tangible, often traumatic, real-world experience of living with this risk.
So if these arrhythmias can be so subtle or so dramatic and with such varied underlying causes, how do clinicians actually embark on the diagnostic journey to uncover and characterize them? What are the guiding principles that shape this systematic evaluation?
The evaluation is indeed guided by several important considerations, forming a very systematic approach for any professional to master. First, we need to understand the clinical presentation fully. Assess the severity of symptoms, minor palpitations, recurrent dizziness, syncope, and identify any provocative factors.
Like exertion, stress, meds.
Exactly. Anything that reliably triggers the arrhythmia.
And then it's about connecting the arrhythmia back to the heart itself and its overall health.
Precisely. Second critical consideration. Determine whether the arrhythmia is associated with a cardiac disease. A comprehensive search for underlying structural or electrical abnormalities. If disease is found, we must establish its prognostic significance, particularly the risk of sudden cardiac death.
Risk stratification.
Absolutely crucial for that and for determining intervention. Finally, we need to define the likelihood of arrhythmia recurrence and understand the symptoms and risk imposed by the recurrence. The bottom line, fundamental for mastery, is that the risks of cardiac arrest and sudden cardiac death are largely determined by the cause of the arrhythmia and the associated underlying heart disease. This guides everything.
So how do doctors actually capture this electrical storm to make a definitive diagnosis? What are the go-to tools for recording these elusive electrical events?
The diagnosis is fundamentally established by recording the arrhythmia itself. Various methods exist. The most basic, often first line, is a standard ECG, a 12-lead electrocardiogram. especially if symptoms are happening then.
What if symptoms are infrequent?
Then we use ambulatory or implanted cardiac monitor, like a Holter monitor for 24-48 hours, or an event recorder the patient activates during symptoms, or even long-term implantable loop recorders monitoring for years.
Wow, years.
Yes. And if a patient already has an implanted rhythm management device, like a pacemaker or ICD, these automatically record and store events, providing invaluable data.
And sometimes you provoke it.
In some complex cases, yes, especially for VT or pre-ablation planning, it might be intentionally and safely initiated and studied during an electrophysiologic study in a specialized cardiac cath lab.
The standard 12-lead ECG sounds like a workhorse. Even if the patient isn't actively having symptoms right then, what specific clues can it provide even in a stable patient?
It absolutely is a diagnostic powerhouse. Even when asymptomatic, a resting 12-lead ECG is crucial. It often provides clues to the potential site of origin and, perhaps more importantly, the possible presence of underlying heart disease. We look for key abnormalities.
Like what specifically?
For example, Q waves that indicate prior myocardial infarction, even a silent one the patient didn't know about. Q waves signify electrically dead muscle. We also look for signs of ventricular hypertrophy, abnormal thickening, suggesting conditions like hypertrophic cardiomyopathy.
And it sounds like the ECG can even point to genetic conditions that might predispose someone to VAs, even if their heart structure looks normal. That's truly advanced diagnostic power.
That's where the ECG gets really fascinating. For patients without obvious structural heart disease, specific ECG findings can be the major diagnostic manifestation for several genetic arrhythmias syndromes.
Like long QT Brugada.
Exactly. Critically important conditions like long QT syndrome, Brugada syndrome, and short QT syndrome. The heart's pumping might look normal on imaging, but the ECG provides a direct window into subtle yet dangerous abnormalities in the heart's electrical channels, predisposing to life-threatening arrhythmias.
Yeah.
It's paramount for screening for these often hidden, inherited electrical issues.
So beyond the ECG, what about the patient's personal story, their history, their medications, and those crucial family clues? How do these pieces of the puzzle come together?
Gathering a detailed history is absolutely vital for mastery. Beyond just symptoms, we delve into their severity, provocative factors like exertion or stress. We explore medical history for underlying heart disease. And as we discussed, syncope or near syncope raises concern significantly.
Especially unexplained syncope.
Right, a thorough medication review is also incredibly important. Check for medications that prolong the QT interval, predisposing to torsades. Also, adrenergic stimulants, decongestants, certain drugs, excessive caffeine can provoke PVCs.
And family history that often reveals more than you'd expect, doesn't it? It seems to be a key, yet often overlooked, part of the puzzle.
It's absolutely crucial, often yielding surprising insights for uncovering genetic links. We ask in detail about premature coronary artery disease, cardiomyopathy, or cardiac arrhythmias in close relatives. A history of sudden death in the family, particularly young, is profoundly concerning.
And sometimes the cause of death is mislabeled.
Here's a powerful, often surprising insight. Sudden death victims are often said to have died of a massive heart attack, despite absence of definite confirmation, when other causes such as arrhythmia may have been possible.
Wow.
It highlights the critical importance of detailed investigation, sometimes even posthumously, to understand the true cause, guiding screening for relatives who might be at risk. Need to look beyond the obvious.
So it's not just about what the patient says or what the ECG shows. The physical examination must also provide critical clues that contribute to this diagnostic picture. What exactly are clinicians looking for during the physical exam?
Absolutely. The physical exam isn't just formality. It focuses specifically on looking for evidence of structural heart disease and other systemic clues. Careful assessment of the pulse, regularity, rate, character. Check jugular venous pressure for fluid overload. Listen to lung fields for congestion. And thorough cardiac auscultation for heart sounds, murmurs, extra sounds indicating valve problems or muscle dysfunction.
And clues beyond the heart.
Yes. A truly comprehensive exam looks for less common but important clues. Stigmata of neuromuscular disease, subtle muscle weakness, or neurological signs or dysmorphic features. Unusual physical traits may suggest a genetic arrhythmia syndrome with systemic manifestations. Shows the breadth of connections a skilled clinician looks for.
And then there's advanced imaging, which can actually visualize the heart structure, its function, and any telltale scar tissue. When does that come into play?
Yes, when there's suspicion for structural heart disease, from history, ECG, or exam, then cardiac imaging is warranted. Transthoracic echocardiography, ultrasound, is the most frequently employed for initial evaluation. invaluable for assessing chambers, valves, and pumping function.
And if the pumping function is low?
If it shows depressed ventricular function, low ejection fraction, it significantly increases concern for a risk of sudden death. Prompts further evaluation for the cause, cardiomyopathy, CAD, valve disease. Echo can also reveal ventricular thickening, suggesting hypertrophic cardiomyopathy or infiltrative diseases like amyloidosis.
And then there's cardiac MRI, which sounds even more precise for detecting subtle changes.
Cardiac MRI with gadolinium contrast is indeed more advanced, provides detailed structure and function, but its unique, profoundly valuable capability. It can detect areas of ventricular scar, seen as regions of delayed hyperenhancement.
The scar lights up.
Exactly. Contrast washes out slower from scar. Incredibly relevant because scar tissue, as we discussed, is usually present in patients who have sustained monomorphic VT and forms a substrate for reentry. You might see this illustrated clearly on an MRI image in texts. Other advanced imaging like intracardiac echo or electroanatomic maps also assist, often during ablation.
And finally, a crucial step for many patients is ruling out coronary artery disease, which we heard is the most common cause of VF.
Exactly. In patients at risk for coronary artery disease, CAD, an evaluation to exclude it is always performed, guided by age and risk factors like diabetes, hypertension, cholesterol, smoking. It's a comprehensive approach to ensure all potential contributing factors are identified.
This is where the knowledge truly becomes actionable treatment. How do doctors approach managing VAs given their incredible diversity in presentation and underlying risk? Is it a one-size-fits-all plan?
Absolutely not. Treatment is always highly individualized, guided by the severity and frequency of symptoms, the patient's underlying heart condition, and their overall risk profile. For those benign idiopathic arrhythmias.
No structural disease, no sudden death risk.
Right. Often, simple reassurance and removal of aggravating factors like caffeine or stress management are all that's needed. No aggressive intervention. Very reassuring for those patients.
But for the risky ones?
For arrhythmias associated with a significant sudden death risk, a much more aggressive, often life-saving approach is certainly indicated.
And that aggressive approach often involves the life-saving safety net of implantable cardioverter defibrillators, or ICDs. For us seeking mastery, how exactly do these remarkable devices function to protect patients?
ICDs are indeed remarkable, profoundly life-saving. Primary function: continuously detect sustained VT, largely based on programmed heart rate thresholds, and then crucially, terminate the arrhythmia.
How do they terminate it?
Depends on the arrhythmia. For slower monomorphic VT, it might first try gentle anti-tachycardia pacing, or ATP, a burst of rapid pacing, slightly faster than the VT, to overdrive and interrupt the reentrant loop, restoring normal rhythm, often imperceptible.
And if that doesn't work, or it's faster?
If ATP fails, or for very rapid VT or chaotic VF, then a high-voltage shock is delivered directly to the heart, effectively resets its electrical activity, letting the natural pacemaker resume control.
I understand there are different types of ICDs, specifically one that avoids leads in the heart itself. Can you elaborate on the main types and their respective pros and cons for professional understanding?
Yes. Most common are transvenous devices. Leads thin wires inserted into a vein near the shoulder, threaded into heart chambers, usually the right ventricle. Sometimes extra leads in the atrium and left ventricle for biventricular pacing, or CRT.
But they have downsides.
They do. Risks of vascular occlusion, lead fracture, endocarditis, infection around device leads, and potential difficulty with removal if needed later.
And the alternative, subcutaneous.
Yes, subcutaneous ICDs are newer, placed entirely subcutaneously under the skin. No transvenous lead in the heart. Rhythm sensed by a lead overlying the left chest, like a surface ECG but under the skin.
What's the catch?
The key limitation for mastering the distinction: only shocks can be delivered. No ATP, and crucially, bradycardia pacing is not possible. Can't act as a pacemaker for slow rates. But a significant potential advantage, potentially less risk of device infection.
I can only imagine that getting a shock from an ICD must be incredibly jarring and painful for a conscious patient. What is that experience like, and what are the common complications beyond the shock itself?
It is, very much so. Shocks are painful if the patient is conscious. Important detail for empathy and psychological care often leads to significant anxiety. However, despite discomfort, ICDs are highly effective for termination of VT, unequivocally saving lives.
What's the most common problem?
Ironically, the most common ICD complication is delivery of unnecessary therapy. ATP, or shocks for inappropriately detected rapid supraventricular tachycardia, looks fast but less dangerous, or electrical noise from a lead fracture or interference.
So checking after a shock is crucial.
Absolutely critical. ICDs record and store electrograms from arrhythmia episodes, detailed diagnostic info, retrieved via interrogation, downloading memory, even remotely. Vital to confirm the diagnosis and rule out unnecessary therapy. Long-term, device infection is an important problem, occurs in 1% of patients, though may be lower with subcutaneous.
So given their life-saving potential, when is an ICD actually recommended? What are the criteria for implantation, and what's the overall mortality benefit?
ICDs unequivocally decrease mortality in patients at risk for sudden death due to structural heart diseases, especially post-heart attack with reduced function or certain cardiomyopathies. But there's a crucial general rule. Recommended only if there is also expectation for survival of at least a year with acceptable functional capacity. Ensures meaningful benefit.
Are there exceptions?
Yes, nuanced decisions. Patients with end-stage heart disease awaiting cardiac transplantation, or those with left bundle branch block QRS prolongation, likely to improve function with CRT from a biventricular ICD. For them, an ICD may be warranted despite guarded prognosis.
A bridge or part of therapy.
Exactly. Also, wearable ICD systems, vests with electrodes, available for short-term use if needed temporarily.
And what happens if someone with an ICD starts getting recurrent shocks? That must be incredibly distressing, both physically and psychologically.
Extremely serious, a major challenge. Occurrence of shocks predicts subsequent increased mortality and risk of heart failure. And you're right, beyond pain, repeated shocks, even if appropriate, often induce post-traumatic stress disorder, impacting quality of life.
So how do you manage that?
Managing recurrent shocks is paramount. Often, antiarrhythmic drug therapy, most commonly amiodarone or catheter ablation, is required for suppression, often a combined approach. Critically important. Antiarrhythmic drug therapy can alter the VT rate and the energy required for defibrillation, necessitating careful programming changes in the ICD's algorithms. Dynamic interplay between device and meds.
Let's move to antiarrhythmic drugs themselves, aiming to modulate the heart's electrical system. For those aiming to master this, what are the general considerations clinicians must always keep in mind?
Use is a careful balance. Risks and potential benefit for the individual patient. Key challenge. Efficacy and side effects, often not predictable. Requires trial and error. Most adverse effects are non-cardiac and minor, though can limit use.
What about cardiac side effects?
The major one is the dreaded proarrhythmia. The drug increases arrhythmia frequency or causes a new dangerous one. Aggravation of bradyarrhythmias, slowing the heart too much, also common. And most drugs have multiple effects, interacting with more than one channel, making impact complex.
So where do beta-adrenergic blocking agents, or beta blockers, fit into this strategy? They seem like the foundational first line for many heart conditions.
They often are, for good reason. Many VAs are sensitive to sympathetic stimulation adrenaline. Beta blockers diminish the electrophysiologic effects of this, calming the heart. Their relative safety makes them the first choice of therapy for most VAs, particularly exercise-induced and idiopathic arrhythmias.
But not always strong enough.
Efficacy is limited for most arrhythmias associated with structural heart disease, may not be sufficient for complex scar-related VTs. Major adverse effects: bradyarrhythmias and negative inotropic effects, weakening pumping force, problematic in heart failure.
And calcium channel blockers, are they ever used for VAs?
Yes. The non-dihydropyridine ones, diltiazem and verapamil, can be effective for some idiopathic VTs, especially from outflow tracts. Low risk of proarrhythmia, a significant advantage. But adverse effects. Negative inotropic and vasodilatory effects can worsen hypotension, used cautiously in heart failure.
Then we have sodium channel blocking agents, or Class I drugs, which modulate conduction. What's their specific role and mechanism?
Primarily work by blockade of the fast inward sodium current, Class I antiarrhythmics, oral, mexiletine, quinidine, disopyramide, flecainide, propafenone. 4. Lidocaine, quinidine, procainamide, often for acute use. Action: depressing cardiac conduction and membrane excitability, slowing the impulse. Often seen on ECG as prolongation of QRS duration.
Making it wider.
Yes. Important note: some, like quinidine, disopyramide, procainamide, also have potassium channel blocking effects, prolonging QT interval, giving additional Class III action.
What are the key risks and considerations with these Class I drugs, especially in patients with existing heart disease?
Significant potential proarrhythmic effects. Can worsen or cause new arrhythmias, and crucially, with the possible exception of quinidine, also have negative inotropic effects, weakening pumping. This may have contributed to the increased mortality observed when some were administered chronically to patients with prior myocardial infarction in trials.
So risky and damaged hearts.
Yes. Because of these risks, Long-term therapy is generally avoided in patients with structural heart disease, especially reduced ejection fraction, but may be used to reduce symptomatic arrhythmias in patients with ICDs, supplementary, with careful monitoring.
Moving on to potassium channel blocking agents, or Class 3 drugs, how do they work and what are their primary effects?
Class 3, like sotalol and defibrillators, primarily block the delayed rectifier potassium channel IKR. This prolongs action potential duration, QT interval, and the cardiac refractory period,
Lengthens recovery time.
making the heart less excitable. Sotalol also uniquely has non-selective barinergic blocking activity, acts as a beta blocker too, shown modest effect on reducing ICD shocks.
So they're effective, but they sound like they come with significant risks, particularly the torsades de pointe we discussed earlier.
They do. Critical point for mastery. Major proarrhythmia risk. Torsade de pointe, that twisting polymorphic VT associated with QT prolongation. Serious, potentially fatal side effect occurs in 3–5% of patients.
And kidney function matters.
Yes. Both sotalol and defibrillators are excreted via the kidneys. Dosage adjustment or avoidance needed in renal insufficiency. And must be avoided in patients with other risk factors for torsade, like existing long QT, low potassium, significant bradycardia. Increases risk synergistically.
And then there's amiodarone, which seems to be regarded as the broad-spectrum powerhouse, but I've heard it comes with a lot of significant caveats and side effects.
Amiodarone is indeed the most potent broad-spectrum powerhouse. Mechanism is complex, blocks multiple cardiac ionic currents, sodium, potassium, calcium, and has sympatholytic activity, dampened sympathetic effects, widely regarded as the most effective antiarrhythmic drug for suppressing VAs, especially with structural heart disease.
Can be given IV or orally.
Yes, intravenously for life-threatening arrhythmias acutely. Chronic oral therapy effects develop over days due to long half-life, often more effective than sotalol in reducing ICD shocks.
What about its side effects? You said caveats, and that's a crucial part of mastering its use.
Cardiac adverse effects include bradyarrhythmias, a major consideration. Ventricular proarrhythmia can occur, but torsade de pointe is rare compared to other class 3s. However, the non-cardiac toxicities are a major problem, the primary limitation for long-term use.
How major?
So significant they can contribute to drug discontinuation in at least a third of patients during long-term therapy, include hyper and hypothyroidism from iodine content, pneumonitis or pulmonary fibrosis, severe lung toxicity 1%, common photosensitivity, potential neuropathy, and ocular toxicity.
Requires lots of monitoring.
Yes, systematic monitoring recommended during chronic therapy, including assessment for thyroid, liver, and pulmonary toxicity. High-maintenance drug, also detail. Intravenous administration via peripheral vein for 24 days can cause severe peripheral thrombophlebitis, needs central line for long infusions.
And there's a related drug, dronedarone. How does it compare?
Yes, dronedarone. Structurally similar, but without the iodine moiety. Avoids thyroid issues mostly. However, efficacy for VAs is poor and shown to increase mortality in patients with heart failure. So, not typically used for treatment of VAs in that group. Highlights complex pharmacology.
Beyond drugs, there's catheter ablation for VT, which sounds like a way to physically pinpoint and eliminate the source. A very targeted approach.
Catheter ablation is indeed highly targeted, increasingly sophisticated, typically performed by applying radiofrequency RF current to cause thermal injury by resistive heating of cardiac tissue responsible for the arrhythmia.
A tiny controlled burn.
Exactly. Creates a precise lesion to eliminate the faulty pathway or circuit. Methodology involves navigating an electrode catheter with an electroanatomic mapping system into the heart. Advanced mapping maps local electrical activity to identify the ventricular myocardium causing the arrhythmia substrate.
Success depends on location.
Yes, the size and location of this arrhythmia substrate determine the ease and likely effectiveness and potential complications.
How do they actually reach these specific areas? Are there different access routes?
Depends on origin. Most commonly from the endocardium inner lining. Reach from an endovascular approach via femoral vein or artery. Less commonly from the subepicardium outer surface. Requires percutaneous pericardial puncture, inserting catheter into pericardial space for mapping ablation from outside.
And if the VT is related to scar tissue, how does that change the approach? Sounds complex.
For scar-related VT from prior MI or cardiomyopathy, ablation targets abnormal regions in the scar, facilitating reentry. Much more complex than ablating a single spot. Because these scars often contain multiple reentry circuits over relatively large regions, extensive areas of ablation are required. identified as regions of low voltage displayed on anatomic reconstructions by mapping system.
What are the typical outcomes and the inherent risks for this kind of complex procedure?
Ablation in these often sick patients carries procedure-related mortality 0.53%. Outcomes generally better for patients with prior infarction and VT than non-ischemic cardiomyopathies, where scar is more variable, often deeper or outer surface harder to reach. But for patients with very frequent or incessant VT, ablation can be life-saving.
And are there exciting new technologies on the horizon or even already in early use to make ablation even more precise or less invasive?
Absolutely. Constantly innovating. Methods of delivering ablative energy to intramural areas, deep in the wall, or areas requiring very extensive ablation are under development. Includes advanced needle catheters, delivering energy into intramural sources.
And that radiation therapy thing?
Yes. Here's where it gets really interesting. Stereotactic body radiation therapy, SBRT. Classically for tumors, now explored to direct high-dose radiation therapy to a specific portion of the scar substrate. Goal, non-invasively ablate VT, using radiation to create tissue damage like RF ablation, but externally. Early studies encouraging. Fascinating glimpse into future possibilities.
That's truly incredible. What about those more benign idiopathic VTs and PVCs? Is ablation an option for them too? And what are the success rates like?
For idiopathic VTs and PVCs without structural heart disease, catheter ablation typically has a higher success rate for preventing recurrent arrhythmia than scar-related VT, because they usually originate from a small, singular focus. Easier, safer targets. Long-term arrhythmia-free survival is excellent, offering a definitive cure.
Finally, for those incredibly difficult, truly refractory cases where drugs and catheter ablation aren't enough, it sounds like there's still arrhythmia surgery, but perhaps as a last resort.
It truly is. Arrhythmia surgery considered when antiarrhythmic drug therapy and catheter ablation fail or are not an option. Techniques. Surgical cryoablation, extreme cold, often combined with aneurysmectomy, can be effective therapy for recurrent VT due to prior myocardial infarction, used in some non-ischemic cases. But, important note, few centers now maintain the expertise due to complexity in ablation's increasing efficacy, sometimes used as an adjunct to ventricular assist device implantation in very complex end-stage scenarios. #tag outro.
We have truly taken a profound deep dive today into the complex world of ventricular arrhythmias. We've journeyed from understanding their fundamental electrical origins, how signals arise from focal points or reentrant circuits, to systematically dissecting their diverse forms, from PVCs all the way to VF. We've meticulously explored how they manifest or hide and the intricate diagnostic methods.
And we've thoroughly covered the multifaceted treatment landscape, hopefully giving you a mastery of this field, from simple reassurance to ICDs, the complex balance of meds, precision ablation.
Right down to surgery and even things like SBRT.
Exactly. This deep dive has truly aimed for a comprehensive understanding, like the elite professionals have.
What's abundantly clear is that managing VAs is intensely individualized, demands deep understanding of each patient's symptoms, condition, arrhythmia characteristics, no single playbook, always tailoring with vigilance and precision.
So as you reflect on the heart's incredible electrical complexity and how even subtle microscopic changes can manifest in such profound, life-altering ways, what might this deep dive reveal about the broader connections between our physical well-being and that dynamic, invisible electrical symphony within?
And how might this mastery empower you in future discussions about cardiovascular health? Something to think about. Until next time on the deep dive, keep exploring, keep questioning, and keep mastering the incredible complexities of the world around us.